Obstructive pulmonary disease is a preventable and treatable condition characterized by persistent respiratory symptoms like dyspnea and cough with progressive airflow limitation, which is due to alveolar and airway abnormality, which is in turn caused due to noxious particles and gases. The definition is quite extensive, but you'll understand this definition once we discuss idiopathophysiology of the condition. So the conditions which are associated with chronic obstructive pulmonary disease is we have emphysema, chronic bronchitis, and small airway disease. Under emphysema, we have abnormal and permanent dilatation of the structures which are distal to terminal bronchiole. Here we have the terminal bronchiole, distal to it we have respiratory bronchioles, alveolar ducts or a respiratory duct, and followed by alveoli. If there is permanent and abnormal dilatation of structures distal to terminal bronchioles, it is considered as emphysema, where small airways is injured. And also, we don't see obvious fibrosis in this condition, emphysema. Other condition, we have chronic bronchitis, which majorly involves large airways like trachea and bronchi. The chronic bronchitis is defined by chronic productive cough for more than 3 months, which is present for at least 2 consecutive years, with the other condition causing this chronic cough like bronchiectasis ruled out. So chronic bronchitis is chronic productive cough for more than or equal to 3 months, at least for 2 consecutive years. Then we have small airway diseases where small bronchioles are constricted, leading on to this disease. So in all the conditions of COPD, that is emphysema, chronic bronchitis, and small airway disease, there is airflow limitation. Please note this point. The risk factors for COPD is we have environmental risk factors like pollutants. Smoking is one of the common risk factors which is causing this COPD. In 15 to 20% of smokers only, we see COPD. The reason why we see in only 15 to 20% of patients is the genetic predisposition and environmental factors also influence the occurrence of the disease COPD. And also secondhand smoke is also a risk factor for developing COPD. Indoor air pollution and the toxic pollutants released from industries are risk factors for developing COPD. If the mother smokes during pregnancy, or the baby has low birth weight, or there is bronchopulmonary dysplasia of the baby, and if the child has a recurrent respiratory tract infection in the childhood, is being found with, it's been seen that the children with these conditions has increased risk for COPD. The recurrent respiratory tract infection and infection with HIV and TB are found to be risk factors for COPD. Those factors influencing the occurrence of COPD are genetic risk factors like alpha and antitrypsin deficiency, TG, the polymorphism in TGF beta 1 gene and SERPIN-E2 gene. And if the patient has airway hyperreactivity, they have increased risk of developing COPD. Why these genetic abnormalities causes COPD? We'll see it shortly. Now coming to pathophysiological process that occurs in COPD, we have airway limitation in all the conditions associated with COPD. First, we'll see the pathophysiology of chronic bronchitis. I already told you that in chronic bronchitis, the large airway are predominantly involved, like trachea and bronchi are predominantly involved. These patients with chronic bronchitis will have cough with airflow limitation, dyspnea. The cough is due to, before that, in all the conditions of COPD, there are environmental pollutants, smoking and other environmental pollutants, air pollution. These irritants will cause infiltration of T cells, macrophages and neutrophils into the lungs, into the airways, thereby causing inflammatory response in the airway. So this is common in both of this condition, that is chronic bronchitis and emphysema. After this inflammation, in case of patients with chronic bronchitis, they will have submucosal gland hyperplasia and hypertrophy in the large airways, and increase in hyperplasia of goblet cells in small airways like small bronchi and bronchioles. This leads to increased production of mucus, which causes the obliteration of lumen. It fills the lumen and causes dyspnea, and also it causes cough. We have reed index, which tells that, which is nothing but the ratio of thickness of mucus secreting glands to the thickness of bronchial wall. Normally, it is 0.4. If the patient has the reed index more than 0.51, it suggests chronic bronchitis, and amount of sputum produced by patients during cough is directly proportional to reed index. So we have cough due to hyperplasia, hypertrophy of submucosal gland, and due to hyperplasia of goblet cells, which is secondarily due to the inflammatory response and production of interleukins and other growth factors during inflammatory response. We have airflow limitation in chronic bronchitis, which is due to fibrosis of small airway, mainly caused by TGF beta 1, and then the mucosal plugging causing airflow limitation. So the patients will have dyspnea in case of chronic bronchitis. Coming to emphysema pathophysiology, in emphysema, the patient will have genetic abnormalities in the alpha-1 antitrypsin gene leading on to alpha-1 antitrypsin deficiency, or they have polymorphism in TGF beta-1 gene, which causes fibrosis. So these genetic abnormality, mainly alpha-1 antitrypsin deficiency, and also reduced amount of antioxidants, will impair the normal protective mechanism in the lungs, which usually acts against the normal inflammatory response in the lungs. When these protective mechanisms are lost, the normal inflammatory response in the lung causes extensive damage to the host tissue, along with the damage to the foreign particles like toxins. So the alpha-1 antitrypsin and serpin E2 is responsible for inhibiting neutrophil elastase. This neutrophil elastase are normally secreted by neutrophils during inflammatory response. This neutrophil elastase will cause extracellular matrix damage. So since this inhibition is lost due to reduced amount of alpha-1 antitrypsin or serpin E2 gene mutations, it causes the extracellular matrix damage in the lung parenchyma, causing destruction of alveolar wall and respiratory duct. So what happens after this destruction of alveolar wall and respiratory duct? There will be abnormal dilatation of these structures which has been destroyed. So we saw in the definition of emphysema that it is an abnormal permanent dilatation of the structure distal to terminal bronchiole, the pathophysiology of which we saw now. Normally, physiologically, the driving pressure is more than airway pressure. What is the meaning of it? The meaning is, whenever we know that the inspiration is the active process and expiration is a passive process. During expiration, there will be elastic recoil of the lungs, and there will be intrapleural pressure causing expiration and expulsion of the air from the lungs. When there is destruction of extracellular matrix by the neutrophil elastase, it reduces the elastic recoil capacity of the lungs. Thereby, normally the driving pressure will be more than airway pressure. No, the driving pressure is nothing but the intrapleural pressure plus elastic recoil pressure. So the elastic recoil pressure will be reduced due to its destruction by neutrophilic elastase. So when the expiration process is going on, before all the contents of the alveoli are expelled, the respiratory ducts, the alveolar ducts will collapse, thereby causing retention of the air inside the alveoli, that is trapping of air inside the alveoli, causing the hyperinflation of the lung and the symptoms that we see in emphysema. This is about the etiopathic physiology of emphysema. Let's see the different types of emphysema based on the structure involved. The lungs, we have acini or functional unit of the lung, that is the structures distal to terminal bronchioles. Those are respiratory bronchioles, alveoli and alveolar duct. We have interlobular septum in between these alveoli. This is the normal image of normal structures. We have four types of emphysema based on the part of the acini involved. We have centriacinar type, panacinar type, paraseptal type, and irregular type. In centriacinar type, the proximal respiratory bronchioles are involved, sparing the distal alveoli and alveolar duct. Here you can see in this image. In this image, you can see the involvement of respiratory bronchioles, whereas the alveolar duct and alveoli are normal. This is called as centriacinar type. The centriacinar type usually involves the upper lobe of the lung. It's usually seen in heavy smokers, and it's commonly associated with chronic bronchitis. Then we have panacinar type. The name suggests that there is involvement of all the parts of acini. Panacinar type. Here you can see there is involvement of respiratory bronchioles, alveoli, and alveolar duct. The panacinar type usually involves the lower lobe of the lungs. It's usually caused due to the mutations in alpha-1 antitrypsin gene and reduction in alpha-1 antitrypsin levels. We have paraseptal type. The structures adjacent to interlobular septum will be involved here, the paraseptal type. Here you can see the structure adjacent to septum are alveoli and alveolar duct. So alveoli and alveolar duct will be dilated in case of paraseptal type. The paraseptal emphysema usually associated with bullae because it's near to the pleura. We can see bullae. The bullae can rupture, leading on to spontaneous pneumothorax, which is one of the complications of COPD. Then we have the most common type, that is irregular type, where the different structures of the acini are irregularly involved. This is usually seen due to the scar, the old scar due to old tuberculosis scar. So this is about, and also the patients with irregular type can be asymptomatic. These are the four types of emphysema. Those are centriacinar, panacinar, paraseptal, and the irregular type. Then we have clinical manifestations of COPD, chronic obstructive pulmonary disease. Let's divide it into clinical manifestations seen in chronic bronchitis and emphysema. Chronic bronchitis is usually seen in the age group of between 40 to 45 years, whereas emphysema is seen between 50 to 75 years. In chronic bronchitis, the patient will usually have cough with copious amount of sputum. They can have recurrent respiratory tract infections, and they will have type 2 respiratory failure due to ventilation perfusion mismatch. What is this type 1 and type 2 respiratory failure? The respiratory failure, the patient will have hypoxia, which is common to both type 1 and type 2. If along with hypoxia, there is no hypercapnia, it is called as type 1 respiratory failure. If along with hypoxia, if there is concomitant hypercapnia, it is called as type 2 respiratory failure. In type 1 respiratory failure, the CO2 level are not increased, so hypercapnia is not seen. In type 2, the hypercapnia is seen. The type 1 disease is caused due to ventilation perfusion mismatch. It's quite intuitive. The ventilation perfusion mismatch can be due to emphysema. Why in emphysema there is ventilation perfusion mismatch is because the alveolar surface area has been destroyed by the disease process, the neutrophil elastase. Thereby, the amount of alveoli available for air exchange is reduced, leading on to ventilation perfusion mismatch. So there will be type 1 respiratory failure in case of emphysema. And also type 1 respiratory failure can also be seen in pulmonary edema and pulmonary embolism. In type 2 respiratory failure, there will be hypoxemia along with hypercapnia. So why there is hypercapnia? Because the amount of air coming in and going out of alveoli is reduced in type 2 respiratory failure. So there is alveolar hypoventilation. In type 2 respiratory failure, the causes can be chronic bronchitis. Why? Because in chronic bronchitis, the small airways and large airways can be obstructed. The small airways can be obstructed due to fibrosis, secondary to the action of TGF beta 2, And also large airways can be obstructed due to mucosal plugging. This leads on to reduced amount of air entering the alveoli and going out of the alveoli, which causes the type 2 respiratory failure in chronic bronchitis. And also due to reduced central drive for respiration in opioid overdose, we can see type 2 respiratory failure. In myasthenia gravis, due to the impaired action of muscles, we can have type 2 respiratory failure. So we see type 2 respiratory failure in case of chronic bronchitis, this ventilation perfusion mismatch. When there is ventilation perfusion mismatch, we all know that physiologically, when there is reduced amount of air going into the particular alveoli, body responds by causing vasoconstriction, pulmonary vasoconstriction, so that the blood goes to the areas where there is adequate ventilation. So here what has happened? That mechanism fails. Why? Because the chronic bronchitis diffusely involves both the lungs. All the parts are involved. So there is diffuse vasoconstriction seen in the lungs, which causes the pulmonary hypertension in these patients. The pulmonary hypertension can lead on to secondarily the right heart failure, that is right ventricular hypertrophy or dilatation with or without right heart failure, called as cor pulmonale. This is about the clinical manifestations of chronic bronchitis, where the patient will have cough with copious sputum, recurrent respiratory tract infection, and they will have type 2 respiratory failure, and they will have dyspnea, which is the most important symptom seen in both chronic bronchitis and emphysema. On examination, these patients with chronic the chronic bronchitis is called blue blotters, whereas the patients with emphysema are called pink puffers. The reason why these patients are called blue blotters is, sorry, not blue blotters, it's blue bloaters. Because they are called as blue because they can have cyanosis commonly. This is not usual in case of emphysema due to type 1 respiratory failure. They are called as bloaters because secondary to right ventricular failure, that is right heart failure, the patient can develop edema. So they are called as blue bloaters. Auscultation, nothing significant on inspection and percussion of RS. And the findings on auscultation in chronic bronchitis is, we see vesicular breath sounds with prolonged expiration due to obstruction of airflow. This finding is common for both chronic bronchitis and also emphysema, where there is vesicular breath sounds with prolonged expiration. In case of chronic bronchitis, we can hear inspiratory or expiratory rhonchi. Rhonchi are low-pitched snoring kind of sounds, which are usually heard during expiration. It's due to the plugging of large airways, that is obstruction at the level of large airways like trachea and bronchi. So due to mucosal plugging in the large airway, we can have inspiratory or expiratory rhonchi. We can also hear crepitations, which are nothing but popping or bubbling sound, which are heard due to the alveoli and small airways either opening or collapsing suddenly. So this crepitations and rhonchi can change in intensity, or they can disappear completely after coughing due to the relieving of obstruction following coughing. About the examination findings that we see in chronic bronchitis. Then we have emphysema. The clinical manifestation seen in emphysema is majorly severe dyspnea. They can have cough with the scanty mucus expectoration, but the predominant symptom is severe dyspnea in these patients. It usually occurs at the age group of 50 to 75 years. Due to severe dyspnea, the patient will use accessory muscles of respiration, and there will be increased work of breathing. Due to increased work of breathing, there will be washout of CO2. Due to washout of CO2, there will be reduced PCO2, that is carbon dioxide levels in the blood, partial pressure of carbon dioxide. So these patients will have type 1 respiratory failure, whereas the patients with chronic bronchitis can have type 2 respiratory failure because they will have associated hypercapnia in this condition, that is chronic bronchitis due to ventilation perfusion mismatch. In case of emphysema, the patient will have type 1 respiratory failure, where there will be washout of CO2. Sorry, I think previously I mentioned chronic bronchitis as type 1. It's not type 1. The type 2 respiratory failure in case of chronic bronchitis. So what are the examination findings of emphysema? These patients are characteristically called as pink puffers because we usually don't see cyanosis. We only see cyanosis in the advanced disease. And they'll breathe while expiring. They'll make the pursed lip breathing. They'll make pursed lip during expiration in order to give positive end expiratory pressure. The positive end expiratory pressure will act as mechanical splint, preventing the collapse of alveolar duct and alveoli, thereby helping the patients to partially relieve the symptoms. So the patient will be having pursed lip breathing. They are called as pink puffers. On RS examination, on inspection, we can have tachypnea because the patient is having reduced ventilation and reduced oxygen levels. Due to stimulation of peripheral and central chemoreceptors, we can have tachypnea. On inspection, we can see the exaggerated tracheal descent, the indrawing of costal margin, and excavation of sternocleido, suprasternal space, and supraclavicular fossa during inspiration. It is due to increased work during breathing and also due to use of accessory muscles of respiration. We also have Hoover sign positivity in case of emphysema, where normally the subcostal angle, the angle between xiphisternum and right and left costal margin, increases during inspiration. Whereas in patients with emphysema, since the lung is already hyperinflated, it has already pushed the diaphragm downwards. So during inspiration, the diaphragm can't be pushed further downwards during contraction. This leads on to indrawing and the reduce in subcostal angle. That is the angle between xiphisternum, right and left sternal margin. This is called as Hoover sign positivity seen in case of emphysema. On percussion, we have hyperresonant note due to hyperinflated lung. On auscultation, we see prolonged normal vesicular breath sounds with prolonged expiration. This is the clinical manifestations that is seen in chronic bronchitis and emphysema. Then we'll see the investigation findings of this condition, the COPD. The pulmonary function test is the most important test that we perform in these patients. The FEV1 by FVC ratio, that is forced expiration at the end of 1 second, and forced vital capacity will be reduced and will be less than 0.7 in these patients due to airflow obstruction. When the value is less than 0.7, it can be due to COPD or due to bronchial asthma. So we confirm COPD by doing bronchodilator reversibility test. If the patient has increase in FEV1 by 12% or by 200 ml, then it confirms bronchial asthma. If there is no bronchodilator reversibility, that is test is negative, it confirms COPD. Then we have chest X-ray. On chest X-ray, the patient with emphysema, we can see bullae and hyperlucency in the lung. In chronic bronchitis, there won't be any abnormality on chest X-ray. If the patient has right ventricular hypertrophy and dilation and right heart failure, it can be noted on chest X-ray. We'll do HRCT to detect and quantify emphysema. On doing complete blood count, there will be increased PCV or hematocrit due to chronic hypoxemia. The echo findings, we can see the findings of right heart failure associated with chronic bronchitis due to pulmonary. Coming to treatment of this condition, we have medical therapy and surgical therapy. Please note, the smoking cessation and oxygen therapy are the only two management which are seen to affect the course of disease, thereby reducing the mortality. And other diseases like inhaled corticosteroids and phosphodiesterase 4 inhibitors are only used to reduce the acute exacerbation of COPD, and also they give symptomatic relief. Let's see the medical therapy. For medical therapy, patient has been grouped into group A, B, and E. The group A and B patients are having 0 or 1 moderate exacerbation of COPD. What is this acute exacerbation of COPD? Acute exacerbation of COPD is nothing but worsening dyspnea and cough due to the respiratory infections, that is pneumonia, or due to pulmonary embolism or other causes. These causes will cause acute worsening of dyspnea and cough, which is called as acute exacerbation. If the patient has 0 or 1 acute exacerbation, moderate acute exacerbation, with no need of hospitalization, it comes under group A and B. In group E, the patient will have more than or equal to 2 moderate exacerbation or more than or equal to 1 hospitalization due to acute exacerbation of COPD. Now, what is the difference between group A and group B? Group A patients will be having MMRC grade 0 on 1 grade of dyspnea. In group B patients will have MMRC grade more than or equal to 2 for dyspnea. So in group A patients, we give bronchodilators, any bronchodilators, that is LABA or LAMA, which is long-acting beta agonist, beta 2 agonist, or long-acting anti-muscarinic agents. In group B disease, we give both LABA and LAMA. LABA are long-acting beta agonists, which may be formoterol or indacaterol, and we can give LAMA, that is long-acting anti-muscarinic agents like tiotropium bromide. In group E patients, along with these two drugs, that is LABA and LAMA, we give inhaled corticosteroids to reduce the exacerbation seen in these patients. To reduce the future exacerbation, we give inhaled corticosteroids. The indications for giving inhaled corticosteroids are more than or equal to 2 exacerbations per year, which is the criteria for categorizing as group E, or concomitant if the patient has concomitant asthma or blood eosinophilic level more than 300 cells per microliter. So if the patients have even after giving inhaled corticosteroids, the patient develops exacerbations, we'll perform FEV1. If it is less than 50, we can give roflumilast, that is phosphodiesterase 4 inhibitor, or else if this is more than 50 and less than 70, we'll give azithromycin, so thereby reducing the occurrence of pulmonary infections causing exacerbation. In all the patients with COPD, we should give vaccination for Haemophilus influenza and pneumococcus bacteria in order to reduce the frequency of exacerbation. If the patient has hypoxemia, PaO2 level less than 55 mmHg, or he has resting hypoxemia, we can give oxygen therapy to the patient. Oxygen therapy given more than or equal to 12 hours has been associated with significant benefit, and it's been associated with reduced mortality in these patients. The oxygen therapy can be given at home, that is home oxygen therapy. It is given at night or day with portable oxygen concentrators. This is about oxygen therapy. So if the patient has acute exacerbation and advanced stages of COPD, we can also give mechanical ventilator support. We have some surgical therapies in case of COPD. Those are lung volume reduction surgery, where the patient will have symptomatic relief and functional improvement. It is only done in advanced diffuse emphysema. We can perform bulectomy if the large emphysematous bulla, single large emphysematous bulla occupy 30 to 50% of hemithorax. We can perform bulectomy. Or else in case of advanced COPD, we can't do much. We can perform lung transplantation. This is about COPD. To summarize, COPD is a preventable and treatable conditions where we see persistent respiratory symptoms with progressive airflow limitation caused due to alveolar or airway abnormalities. Under COPD, we have emphysema, chronic bronchitis, and small airway disease. The etiopathophysiciology of this condition, risk factors are pollutants, mainly the air pollution and smoking. We have recurrent respiratory tract infections, genetic factors like alpha and antitrypsin deficiency, polymorphism in TGF beta 1 gene and serpin E2 gene, and airway hypersensitivity as the risk factors. We have pathophysiology of chronic bronchitis, where it involves predominantly large airways like trachea and bronchi. Initially, in all conditions, that is chronic bronchitis and emphysema, these irritants mentioned above will cause infiltration of T cells, neutrophils, and macrophages into the airways, causing inflammatory damage. We see cough in chronic bronchitis due to submucosal gland hypertrophy and hyperplasia in large airways, and increased number of goblet cells in the small airways. The airflow limitation is due to fibrosis of small airway due to GGF beta and also mucosal plugging of large airways. The emphysema in genetically predisposed individuals with alpha and antitrypsin deficiency. Second, due to this inflammatory response, There will be, since due to reduced protective mechanism which inhibits neutrophil elastase, there will be destruction of extracellular matrix in emphysema. This causes destruction of alveolar wall and respiratory duct, thereby causing decreasing diving pressure, which lead on to early collapse of this small airway, leading on to the accumulation of air in small airway and hyperinflation of lungs seen in emphysema. In the chronic bronchitis, patient will present with cough with copious amount of sputum, recurrent infection, and type 2 respiratory failure and dyspnea. Examination findings: these patients are blue bloaters. On auscultation, they will have bilateral vesicular blood sounds with prolonged inspiratory or expiratory bronchi and crepitations. The patient with emphysema will have severe dyspnea and they will be cachetic. They will have type 1 respiratory failure. On examination, they are pink puffers. On respiratory system examination, on inspiratory findings, we have tachypnea, and on inspiration, the patient will have exaggerated tracheal descent, indrawing of intercostal margin, and excavation of suprasternal and supraclavicular fossa. The shape of the chest will be barrel shaped in case of emphysema. On percussion, we'll hear the hyperresonant note. On auscultation, we have prolonged expiration with normal vesicular breath sounds. We have oversigned positivity in case of emphysema. We have 4 types of emphysema. Those are centriacinar, panacinar, paraseptal, and irregular type. Irregular type is the most common one. Investigation: we have PFT, pulmonary function test, where if it's FEV1 by FEC, it's less than 0.7 is diagnosis of this condition. And also, the bronchodilator reversibility test should be negative. Consider the patient as COPD. On chest X-ray on emphysema, we can see bulle and hyperlucency. We don't see any abnormalities in chronic bronchitis. On HRCT can be done to detect and quantify emphysema. On CBC, we can see increased hematocrit or PCV. Under medical therapy, for group A disease, we will give bronchodilators, LABA or LAMA. For group B disease, we give LABA and LAMA. In group E disease, along with LABA and LAMA, we give inhaled corticosteroids. If they are resistant, we can give loflulimast and or azithromycin based on FEV1 levels. We can go oxygen therapy to the patient if the patient has PaO to partial presence of O2 less than 55 mmHg, which is given for more than or equal to 12 hours, or commonly more than or equal to 16 hours. It can be given at home using portable oxygen concentrators. On acute exacerbation and advanced stage, we can use mechanical ventilator support. We can perform surgery to reduce the lung volume, that's lung volume reduction surgery. It gives functional and symptomatic relief in advanced diffuse emphysema. We can perform bullectomy if the single bulle occupies 30 to 50% of hemithorax, and also in advanced COPD, lung transplantation should be done. This is all about COPD. Thank you for listening.